Hi there, and thank you for joining us on UnSCRIPted. I'm Angela Kashuba, Dean of the UNC Eshelman School of Pharmacy. We have an amazing community all working toward a shared goal of solving the world's most pressing healthcare challenges. I'm excited for you to hear the unscripted stories of our faculty, staff, students, alums, and partners. Today, I have invited Bill Hathaway, CEO of the Mountain Area Health Education Center, to join me for a conversation. Welcome, Bill. Thanks so much for being here.
Thank you.
So, MAHEC, or the Mountain Area Health Education Center, is turning 50 this year, which is very exciting. Congratulations.
Yeah, big birthday for anybody, and especially for us at MAHEC.
Yeah, so for those who don't know what MAHEC is or what the AHEC system is, can you talk about MAHEC and the beginnings of MAHEC?
Sure, happy to. We founded 50 years ago, came out of legislation from the federal level that set up a system of area health education centers across the country. The goal to recruit, train, and retain the healthcare workforce of tomorrow. In 1972, give or take, the state put legislature forth to create 9 AHECs, and MAHEC is one of those.
Okay. Let's talk about the history of MAHEC. Where was it focusing? How was it starting? What were the early initiatives, and how has it grown over time?
Yeah, the early initiatives were pretty straightforward. It was to create a family medicine residency program so we could get primary care doctors into rural western North Carolina where there was a lack of access to care. We focused for the first 20 plus years on family medicine residency training. We grew from 4 initial residents to now over 12 per class. And then over time, we've added a host of other residency programs such that we now have over 225 residents and fellows in training at MAHEC.
Wow, that's tremendous.
Yeah.
In terms of impact, what are you most proud of?
While we know that we provide high quality technical care, we also know that we create compassionate and caring physicians. That's critical. I think the thing that we're most proud of is that we've kept those highly qualified and trained physicians who share our ethos in the community. If you look back to the mid 70s when we were really tracking this data, 50+% of our graduates in our residency training programs have stayed in North Carolina, and over 80% of those have stayed in Western North Carolina.
That's tremendous.
Well, yeah, it's really amazing. It's remarkable. 1 in 3 of the family medicine providers in Western North Carolina has roots in MAHEC. And so when you think of what we're proud of, well, that's a fact-based number. We're not proud of that, but think of the impact that those providers have had on their communities. They've touched millions over time of individuals. They've created help and value for families when they're most in crisis.
Yeah, that's tremendous. The School of Pharmacy has campus in Asheville with a very similar purpose to use place-based training to retain professionals. And we're very proud of the fact that we're part of UNC Health Sciences at MAHEC. Can you talk about the history of UNC Health Sciences at MAHEC?
In 2009, there were a group of people in the Western North Carolina who wanted to bring a medical school to Western North Carolina, a 4-year program much like they have on the eastern side of the state at ECU. That never came to fruition, but we began a partnership that has transformed our community and our organization with UNC through the School of Medicine, having 3rd and 4th year students join us up on our campus. We added the School of Pharmacy, as you know, in partnership with UNC Asheville in 2011. My memory serves, correct me on the dates if I get any wrong. And then have subsequently developed partnerships with Gillings School of Global Public Health and the Adams School of Dentistry. And that has rounded out what I consider our UNC affiliation crown, the 4 jewels in the crown. I think there's opportunity for some more. We had some meetings earlier today with nursing and social work. But that partnership has been huge for us and our community in terms of augmenting that workforce pipeline and that training mission.
Yeah, and it's been really significant for our students as well to be in the communities, working in an interprofessional way and team-based care, and seeing how healthcare can really be delivered effectively, efficiently, and the longitudinal experiences in these communities that these training programs provide is really impactful.
Yeah, you mentioned two things I think need to be really emphasized. One is the interprofessional nature of the care that we deliver.
Yeah.
We have organizational goals, and one of our 10 goals is to augment the interprofessional education of our students. We are big enough to have all 4 schools on our campus, and yet we're small enough and de-siloed enough where we can actually create programs that result in really high quality educational experiences. And so we know that people stay where they study, right? And so if you train in a rural-based setting and get exposure to the joy and opportunities in that area, there's a much higher likelihood, which we've seen in pharmacy and all of our programs, of retaining those students.
Yeah. Can you talk about the healthcare for rural North Carolina, how you see it now in general, and what the opportunities are for the future?
Yeah, it's access is number one, particularly around primary care.
Yes.
And so we are doing everything we can to improve care delivery that's close to home. I think of maternal fetal health as an example. We're in a crisis in our country around maternal fetal health. Our outcomes are not where they need to be compared to the other industrialized nations in particular, and they're particularly subpar if you're economically disadvantaged, or women of color in particular have worse outcomes, even adjusted for socioeconomic factors. So we, as an example, are committed to addressing that, and we know that rural labor and delivery suites are evaporating, right? Yeah. So MAHEC has put 2 practices out in the community, one in Transylvania County and one in Franklin for maternal health care, because as I tell my students, the fact that there's no labor and delivery suites in those communities does not mean people aren't out there making babies, right?
Right.
And they need that help. And the outcomes don't get determined in the delivery suite. They get determined well in advance.
Yes.
So we're trying to address access in that area.
If we were sitting here 5 years from now, what would you love to see have transformed at MAHEC?
It's clear to me, and I don't think this is unique to MAHEC, especially in a rapidly or continually changing healthcare environment. It's clear to me that the things that we did that got us here, that have made us so successful, are not necessarily, and certainly not right now, going to be the things that are going to make us successful moving forward, right? We are going to have to change. I think we will see an increasing move towards, I hope we'll see an increasing move towards care delivery models that really provide value-based care, okay? So much of our care is dictated now is not by what's needed for our patients, but by how we get reimbursed.
Yes.
And we need systems that reimburse us for the best way to care for the patients, the tail's wagging the dog on this one.
Right.
So I would hope that in 5 years we'll have created really interdisciplinary team-based care that has information systems that feed us all we need to know to predict who needs our care in advance of when they're going to need the care, that we have team-based approaches with social workers and pharmacists and nurses and transportation people and others who can help address all of the needs of these patients, in addition to the providers, physicians, advanced practitioners on those teams, and learners. And I want to we want to be not just the best place to teach people how to be a pharmacist, teach people how to be a doctor, but teach people how to practice in an ideal, optimized, team-based, patient-centric care delivery model.
That's an exciting vision. I love it.
A lot of pie in the sky, but if we
it's
don't
good.
Aspire for it, we'll never get there, right?
Right. No, it's terrific. And so you mentioned, being able to predict who might need care even before they know they need it. So let's talk a little bit about AI. And how you see AI fitting into medicine and fitting into patient outcomes. How are you thinking about AI currently?
There are so many different ways it could be valuable. I would like to see AI soon help create the documentation that's
Yes.
for the visits, because it's a wasted step.
Yeah.
You know, if we could have artificial intelligence to help create a physician note that's even better than the note the doctor would create in the first place, or the
Right.
pharmacist provider would create in the first place, we've saved time and it could be better and more accurate.
Yes.
So that's a very practical aspect, which I don't actually see as being so far away.
Right.
Listening technology and natural language processing
Right.
should be able to help us with that. As we move down the line, using the myriad of algorithms and issues that we could work on to predict in the future, as I alluded to before, like this patient lives in this county, they're this old, they have this illness. We know that they're going to need 5 or 6 more touches than someone else, and
Right.
reach out and manage that care. So more complex predictive algorithms around managing the who needs our help.
Yeah, that's terrific. And being able to offload some of those operational activities to allow the clinician more time with patients.
Oh, get people to the top of their licensure, right? What's
Yeah.
the joy in medicine about, and in healthcare about? It's those connections with people. It's
Right.
having someone in their most vulnerable state,
Right.
like when they're ill and they need help,
Yeah.
meeting a stranger, and then you're being able to help them.
Yeah.
And the documentation and the technical aspects and the billing and everything else gets in the
Right.
way.
Right.
It's a bad experience for the patient. It's a suboptimal experience for the provider when it's not optimized. So
Yeah.
if we could use technology to give us more time
Right.
to make those connections, it'd be
Right.
great.
Yeah, no, that's terrific. I want to switch to a little bit of your history. You're a third generation physician.
Yeah, I'm not sure that's right. I think it might be longer.
Oh, is that
yeah,
right?
so I have been doing some Ancestry.com
Yes.
stuff. I discovered in doing more of my ancestral history,
Yes.
I think my great-great-grandfather in the late 1800s was actually a physician.
How about that?
And then his son was one of the next generation was a pharmacist.
Okay.
So I have pharmacy
Okay.
roots too. And then my grandfather was a physician. My mom's grandfather was a dentist. My father was a physician. My father's 2 brothers were physicians. My brother is a dentist. And so there's
So-
a long history of healthcare in the family.
yeah, absolutely.
yeah.
So how?
Oh, and
how is- oh, one more.
my wife's a physician
And your
too.
wife- yeah,
I got to
right.
get that in there.
Right. So how has having healthcare in your history, in your long history, past history, really influenced the way you approach patient care? Because you've grown up with it all around you.
Yeah, so my father was my hero and role model.
Okay.
I didn't know my grandfather so much. He died in 1967. He was a medical corpsman. He was in medical school in 1918 at the University of Minnesota, and he signed up and enlisted to become a corpsman for World War I and went to France.
Wow.
He then came back and graduated from the University of Cincinnati Medical School in 1921, and then he had a practice in northern Wisconsin. And then in 1940, he's enlisted for World War II.
Okay.
And he served in the European theater for 5 years as a surgeon and physician.
Is that right?
And he was the first medical officer into Dachau prison camp when it was liberated.
Wow.
So I did not know him, but he was legendary, and like the shadow he cast across our family because of this, he was of the greatest generation, to quote Tom
Yes.
Brokaw,
Yeah.
has had dramatic and profound implications for the rest of my family, and secondarily for me. All 3 of his sons went into medicine because of that. And then my father, who was an internist and nephrologist, was my role model and had a large influence over me picking, not going into surgery as an example, not because he didn't want me to be a surgeon, but because I wanted to be a more of a primary care person.
Mm-hmm.
And so I had the benefit, and I know cardiology is not primary care, but I had long-standing relationships
Yeah.
with my patients, which I crave.
That's amazing.
Yeah.
That's a really good story.
Yeah.
And I know we could go on. We'll have to have you back.
It's great.
Because we've got so much more to talk about.
Yeah.
But I appreciate your time today.
Yeah, it's my pleasure.
And I highly value the partnership that we have as a School of Pharmacy with MAHEC and with you and with UNC Health Sciences at MAHEC. Our students are just tremendously, they benefit tremendously from this partnership.
Yeah, you value the partnership half as much as we value the partnership. Yeah.
Well, thank you.
It goes both ways.
Yeah, I appreciate it. Thank you.
You.
And thank you for watching. We love sharing stories of those who make the UNC Eshelman School of Pharmacy excellent. We hope you will join us for the next episode of UnSCRIPted, conversations with the people who are advancing medicine for life.